Good evening, everyone. It is my honor to welcome you all for this podcast series, a brainchild of our Foxy President, Sunita Tandulwadkar, ma'am. In this podcast, actually 317th podcast, I, Dr. B. Kalpana, Fogsi Infertility Committee Chairperson, will have a conversation with Dr. Vijay Shankaran, sir, who has got an experience of almost 3 decades in his field. Before starting this program, I request Dr. Ashwini Kale, Dynamic Joint Secretary of Fogsi now, to bless this program with few words.
Hello, good evening, sir. A very warm welcome to this podcast series by Foxy. This is a podcast series which happens every day at 8 p.m. since we started this on 10th of January 2025. So we have completed over 300 episodes now. This is conducted by all the 31 committee chairpersons of Foxy. And we at Foxy this year, our theme is preconception care. So we are working a lot towards optimizing the health of women before they actually get pregnant. And I think this is a very good topic chosen by Kalpana, madam. I think heart is the last thing that any woman cares about. So we will have a newer insight and a newer outlook to this topic, which is much neglected. So wishing you all the very best, Kalpana, madam. I think I'll join in from the viewers link for this podcast. Thank you so much for having me.
Yeah, thank you so much for your blessings in the when Madam is not there. Thank you so much. Uh, Vijay Shankar sir, a reputed cardiothoracic surgeon with almost 3 decades of experience in his field, attached to Apollo Hospital, former professor at Madras Medical College, has joined us to have a conversation about heart health. Welcome, sir. You're muted, sir. You're muted.
Now, can you hear me?
Yeah, yeah,
Wonderful, Kalpana. Nice meeting you. Thank you for allowing me to participate in your program.
yeah. So you have been practicing almost for 3 decades. In the
Yeah.
recent years, do you
Yeah.
think that cardiac
Yeah.
disease incidence is increased,
Yeah.
or it is better diagnosed, so we have more cardiac disease in our OPD?
Kalpana, Dr. Kalpana,
Is it?
your question is in these 40 years, has the cardiac disease increased or lessened? No, I see in the olden days, 50 years back, in our country, the the methods, the quality of life was very poor, and the burden of cardiac disease was there, but it was not well treated. So, in these last 10, 15, or 20 years, there a lot of progress is made in medicine. So, the cardiac disease load, the death rate due to cardiac disease has come down fairly considerably in our country. Now, more so, the development of technical facilities like certain biochemical parameters like troponin I, NT-proBNP, ECGs, and echo, better method of studying cardiac function, has definitely helped to identify cardiac diseases in an early stage and treat them better. Whatever it is, the that's probably one of the reasons why the incidence of cardiac disease is there, but it is not as bad as before.
Okay. The problem is many a times cardiac disease is missed even by medical professional. Can you please tell us the warning symptoms that had been ignored or missed many a times?
See, Dr. Kalpana, unfortunately, the presentation of a cardiac disease like coronary artery disease or heart valve disease or cardiomyopathy never does not have a set program. Now, many times patients with cardiac disease usually complain of not the usual left sided chest pain. It could be back pain, or jaw pain, or hand pain, or left arm pain, or some sort of extreme belching or epigastric pain. Now, this has to be assessed properly by a good cardiologist, by any cardiologist who has a good knowledge of cardiac diseases. Okay. Now, unfortunately, but the development of new tests has helped us to catch these diseases at a very early stage. You got
Okay.
me?
Yeah, yeah. Um, you can put down your camera a little bit so that your whole face. Yeah, this is perfect. Uh, Now, even at young age, we
Mm,
hear about major cardiac disease and sometimes even death.
mm.
Why do we get cardiac disease even at 20s or sometimes 25, 30s also?
See, Dr. Kalpana, you see, in our country, I'm talking about our country. I'm not talking about the white man's country. Here, the economy was bad. People used to live in crowded areas where infection due to streptococcus was fairly prevalent. As a result, young children used to get infected by used to develop rheumatic fever, which usually bites the joints and licks the valves. So they used to get mitral valve stenosis, tricuspid valve stenosis, aortic valve stenosis in a very young age. Now, after the economy has become better, the living conditions has become better, the incidence of rheumatic disease in our country has come down significantly in this last 50 years. But at the same time, due to the better economy, better living conditions, we people are now eating different types of food, which increases the incidence of coronary artery disease. Now we see coronary artery disease fairly prevalent in our country. Probably, like diabetes, we are the world's capital. So soon, coronary artery disease, Indians will be the world's capital. Okay.
We have been advising master health checkup
Mm.
for all females and males, maybe after 40. Annual
Yes.
master
Yes.
health checkup is quite popular in every
Yes.
hospital. But
Yes.
even after doing routine master health checkup, we do
Mm,
encounter major cardiac disease in some
mm.
patients. Then, what is the best way to screen cardiac disease and how do we go about?
See, I remember a very famous cardiologist talking to us on a program that if you look at a man's coronary artery after 40 and a woman's coronary artery after 45, you will invariably find a plaque or a plaque in these vessels. Now, these plaques can, in some patients, mature into a block and cause symptoms. In some patients, it doesn't hurt them. So now the incidence of coronary artery disease and rheumatic valve disease is there, but the best way to screen them is one, good physical history, and the new tests like echo, ECG, TMT if they can do it. TMT. Now, if they are positive, you go one step further and do a coronary angiogram, find out if there is any blocks. Okay. Now, if some patients do not want a coronary angiogram or do not want anything, you can do a simpler test called the thallium test, thallium stress test, which gives you fairly decent information from which we can detect whether this patient has got important coronary artery disease. Okay.
Okay.
Mm.
In addition to master health checkup, if something is suspicious, we need to proceed further and then
Yeah,
do
yeah, chef,
background check.
definitely. Master health checkup, most of the times they don't go into a lot of details, like, usual blood tests, lipid profiles. Even if the lipid profiles may be abnormal, but it still it can't predict the coronary artery disease. You need little bit more dynamic disease tests like TMT. But most patients may not want to do a TMT. A much more less dynamic test, less more invasive test is called the thallium test, which also gives you decent information. Now, if TMT is positive, then if the thallium is positive, we go a step further and do a see coronary angiogram. Now, with the present day advent of imaging technology like the CT imaging, what we have here in Tamil Nadu is the 648 CT imaging, which can tell you the amount of calcium in the coronary arteries and the amount of obstruction with just one small injection of 80 ml of dye. Now that's a great advancement in the identification of coronary artery disease in the public. But the disadvantage is the dye. You give 80 ml of dye, it can hurt your kidneys or it can produce a reaction. But even if we do a CT scan to assess the coronary arteries and the calcium score, we still need a coronary angiogram to plan our therapeutic.
Okay.
Okay.
Okay. At least TMT is the basic test in
Yeah,
our.
it's the basic test. Yes, it's the basic test.
Sometimes even fit young persons
Yes.
are dying in gym while
Mm.
doing heavy, strenuous exercise. And
Uh, uh,
what could be the reason? And before going to gym, should everyone clean their heart?
uh,
What is your advice on it? Even very popular actor died in gym.
in Bangalore,
Yes,
there's a famous actor who died in Bangalore.
yes,
Well,
yes.
he should not be jumping into the gym without proper advice. Okay. Now let me go back to the Olympics. Now in Olympics, all athletes should undergo two tests: echo to assess the size of the aorta and to assess if there is hypertrophic cardiomyopathy. Okay. Now, if they have that, don't think that everybody in the world can do all those things. But they don't do that and they come here. And that's one of the reasons why some people running very fast suddenly drop dead. Or somebody who is pushing a basketball up into the air and trying to get it, but he drops dead. This is because of an unidentified health conditions like coronary artery disease, hypertrophic cardiomyopathy, or any other disease involving the heart, which can become violent when they exercise too fast or too hard. Okay, that's why some of these young people, some of these young people, when they are exercising, they get into a problem.
Okay. So now various watches like Apple watches are marketed in such a way that it not only pulse rate and calories, but also it can alert
Uh,
us about our cardiac disease if we encounter something. Is it really true? And what is your version on it, sir?
but the Apple watches does give you information about the heart rate, the blood pressure, and any irregularities. But it's up to the guy who wears it to identify that he has developed this problem and approach a doctor for help. But they do not in any way replace a good consult with a doctor, a good physical examination, and a thorough examination by the present day available modalities like ECG and echo. They may probably help you to to doubt that there is something wrong, but it's up to the man who is wearing it that he's having a problem. But that's the problem. There is people who wear it may be ignorant about what's happening to them.
Okay. That means, will it be useful for a cardiac patient who had undergone some
Yeah,
conservation?
you got to train them. You got to train them. You see that these are the problems that you made. You got to watch out in your watch, and if that is so, and if it gives you a warning, then you got to approach. You got to see the doctors. Okay.
Oh. So coming into your field
One
problem.
minute, 1 minute, Dr. Kalpana. You said young people who develop heart attacks.
Yes.
Now, there is also other factors which can cause this, the genetic factors. There's usually when people who have an unhealthy lifestyle, smoking, tobacco use, high blood pressure, high cholesterol, diabetes, obesity, or physical inactivity, all this can predispose to young people developing a problem. Mind you, in this era, it is not like olden days. Young people went to work in their farms, they worked very hard. They were not obese. Our grandfathers and grandmothers, they were always working. But the present day folks, they are too much at their liberty. They tend to put on weight, but they don't want to exercise. Now, these are the people who get into a problem. Okay? And mostly more potent is the development of use of cocaine and amphetamine. And Okay?
Okay. Once the cardiac disease is diagnosed, either they go for stenting or CABG. How do you come to a conclusion in borderline cases? Will you decide towards being a cardiothoracic surgeon naturally?
Yeah.
Is it towards CABG or
No, no, no,
to
no, 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 Dr. Kalpana. A surgeon is trained how not to operate waste unnecessarily. That's the most important thing. We try not to because these operations and surgery does carry a risk to life. It is not like appendix. You can get away, do an appendix and get away unless it's a devastating complication there with a pus and all that stuff. But in heart surgery, for some reasons, there's a 1 to 1% mortality. Now, that is not, we cannot explain by any other method that this carries why does this problem occur? There are certain conditions which we do not have control. When such is the case, most of the coronary patients and valve patients, they are they're normal looking people. You can't differentiate them from between you and the patient that he's sick and he carries a time bomb in his body. But we have to be careful about offering our surgical. We keep surgery as a last resort. Initially, we try a medical treatment. And if the medical treatment doesn't fit into the description of his betterment, we offer a much more a robust technique uh, called the stenting. Now, that's become very, very popular after the invention by Dr. Andreas Grunzig in Switzerland. And he went to the United States and perfected the technique so well that it's become so robust. Again, due to advancement of technology, these stents can work for a long time with the addition of a drug in the stent. Now, surgery comes into place when certain all narrowings cannot be treated by stenting. And when such is the case, the cardiologists feel that stenting cannot be done successfully and it cannot yield long-term results, then surgery is preferred. But let me tell you, as a surgeon, I'm not biased against stenting. Surgery is an excellent treatment. It gives you better long term results. The use of the internal mammary artery in the left anterior descending artery is a cure for life. People with a patent internal mammary artery in the left anterior descending artery need not be treated with any other form of treatment, or they have a better quality of life, better longevity when compared with a stent. Okay, but I am sure the cardiologists, your friends, will not agree with me, but 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 that is the truth because the first internal mammary artery was used by a doctor in New York, by Dr. Green. And then it became popularized in the Cleveland Clinic, where nearly 1,000 internal mammary were used in a matter of 1 year. And they followed these patients up. After 30 years, nearly 95% of the internal mammary artery was open. So they have come to a conclusion. Those patients who have an internal mammary artery in the main artery, and also another internal mammary, namely the right internal mammary artery associated with it, they have a better long-term survival than drugs or any other form of stenting. But stenting is definitely useful in acute situations. Suppose a patient walks into your emergency with chest pain and he's sick or chest pain. This stenting can definitely relieve his pain, improve his blood supply, and prevent a fatal arrhythmia. So there's an immediate relief of pain and a longevity and a fatal in itself by a stent. But the long-term results of stenting is still questionable. It cannot be internal mammary artery, but we cannot do internal mammary artery implantation in an acute case. So stenting has completely replaced any surgical intervention in an emergent state.
You've been doing surgeries almost for 30 years.
Yes.
Do you think surgeries have become safer compared to olden days with recent advances?
Yes, ma'am. In the olden days, when we started surgery, when I joined the cardiothoracic department, the commonest cause of death, third cause of death, was cardiothoracic surgery, coronary artery surgery, because the conditions and the advancement of medicine was at a low ebb. So many patients died of coronary artery surgery. Why? Why not in this country? In this country, why not in the United States? You know the lady, the famous singer P. Sushila? You're
Yes,
from South or you're from North?
I'm from South only.
Yeah, she's a famous singer. Her husband was a young man, 45 years old man. He had an asymptomatic coronary artery disease. The poor gentleman, somebody told him that you go to America and get operated. He died on the table. See, see, at that time, even in the United States, that's in I'm talking in the 1980s, 1985, so 1987. At that time, even in the United States, the quality of coronary artery surgery was there, better than rest of the world, but still it yielded very poor results. What about one of our famous professors of diabetes who went to Houston for a coronary artery surgery? He died because you see, death was fairly common in the early stages. I remember the famous surgeon Denton Cooley coming to Bombay and operating on Breach Candy Hospital on four or five patients. Mind you, all patients died. That's probably because the facilities in our country were very poor, even though he was technologically a far superior man, but yet facilities were not good. But now, in this era, the mortality rate for coronary artery surgery with good heart function should be zero. In a clinic like Cleveland Clinic, it is zero. Evo. But in our country, it is now becoming very, very better. But when the heart function is poor, the mortality is slightly on the higher side. Now it is becoming very, very safe as any other operation, like your removal of uterus too. You're a gynecologist, isn't
Yes,
it?
yes.
Yeah.
So now, obviously, with few investigations, cardiac disease is overdiagnosed or better diagnosed. We can tell in another way.
Better diagnosed. Better
Yeah, better
diagnosed.
diagnosed.
Yeah.
So, do you think that our treatment modality is also increased? Stents are overused, or CABG is overused, or?
Uh, I'm not able to answer that question. You see, there are a lot of surgeons who will never misuse their skills, and there are a lot of cardiologists who will never use their skills for unnecessary purposes,
Mhm.
even though there may be a monetary gain. But I think, as a doctor, and I think as fellow doctors, they would never like to put a patient in a bad shape or make the patient spend unnecessarily by their intention to make some money. That's my general feeling. I have not come across any cardiologist in my place where I work to do a stenting unnecessarily or any surgeon doing an operation unnecessarily in cardiac surgery. I don't know about other patients, other surgery. I think as doctors, uniformly we have a we have a lot of loyalty towards our patients. You know, we don't want to hurt them because with our intention to make money. Okay,
No,
but
I'm
I
not
think.
asking in that aspect.
Hmm.
Sometimes even borderline cardiac disease is diagnosed, better diagnosed. So, to avoid future risk, are we going for mm, more stenting and in that way? I'm asking. I'm not
Yeah, yeah.
asking.
No, 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 I can answer that question better, Dr. Kalpana. We have the most studied operation in the world is coronary artery surgery. Most studies. The studies are so extensive. They clearly tell you when to operate, when not to operate, where to operate, how to avoid an operation. When such is the case, we are very, very sure for our indications for operations. Like, for example, if a man comes with a single vessel disease, we will not touch him. And if there is a localized near obstruction, we'll straight away send him to the cardiologist to get stented. Similarly, the cardiologist, if he sees a narrowing in the coronary artery, which is long, irregular, and multiple, he won't bother to stent. He will send to the surgeon for him to put a couple of grafts. So it varies, Dr. Kalpana. I'm not sure. I won't be able to answer the question ethically or morally.
Okay. So, you've been seeing patients operated almost for 30 years. What are the common mistakes the patients do after surgery?
Yeah, the common. Now, so most of the patients, some
Sometimes I
patients,
see few patients after stenting also they go for strenuous exercise and go for heavy tournament
work.
like shuttle tournament, and sometimes I fear about their heart, but they don't fear.
Yes, that's where they get into a problem. You see, we allow all patients. This is we are there is a completely regimented way of looking after these patients after surgery. The American College of Cardiology has given us special instructions that these patients cannot overstretch themselves until 6 weeks. They are made to do graduated exercises. Like for example, in the first week, 10 minutes 6 times. Second week, 15 minutes 4 times. And the end of 6 weeks, you should be able to put on half an hour of morning and half an hour of evening slow walk. Okay. Now this helps them to rehabilitate themselves and then get into your real life slowly. But unfortunately, some people are in a hurry. So they go about doing all sorts of things. And they ignore some. We tell them when they get operated and go back, be careful. Suppose you have some sort of a discomfort in the chest, which is similar to what you experienced before, or something that unusual that makes you feel insecure, please seek help. Now that's where they go wrong. Oh, nothing will happen. Why disturb somebody? It's midnight. I don't want to stop. But next day morning, they're dead. See, that's what happens in these patients.
So, diet plays an important role to avoid cardiac disease when we are
Yeah,
aging. So,
definitely. Definitely.
can you please tell us about heart health, the lifestyle or diet?
Now, in diet, with simple principle, Dr. Kalpana, reduce your salt, avoid your sugars, reduce your carbohydrates, take lot of animal proteins, especially chicken or fish. Okay, that's the simple principle, and plenty of vegetables, plenty of vegetables. That'll help you. That'll help you. You see, and I think if you stick to the simple basic principles, you should not get into a problem. Alcohol to very minimum. Avoid smoking. And if you have any risk factors like diabetes, hypertension, or family history, make sure that those are very well treated and controlled. Many times we see patients with history of diabetes and hypertension comes to our outpatient department, very high sugars, HbA1c 9.5, and a blood pressure of 160/70. Now, how are we going to help them out? Unless they take care of themselves, we can't. Our any amount of surgery or stenting or medical treatment will not allow. Some people just give up their drugs. They say, "No, I'm okay." They think just walking a little bit, they can have silent ischemia. That is, they can have ischemia without pain. They don't know that. So it is better they follow some certain norms given by given and inferred by lot of lot of statistics.
So, minimally invasive surgery is quite popular everywhere. Some of the hospitals are telling that they are going for minimally invasive surgery for cardiac disease also.
Yes,
Is it
yes.
replacing open surgery now?
Yes. See, the open surgery, you see things better, you do things faster, and you have access to any problem immediately because you see what's up. Mind you, opening the sternum is the least painful operation.
Mm.
Now, minimally invasive is not minimally invasive, it's only a small incision surgery. The surgery is small, but the procedure is big, same as the broad incision. Now, all our problems here in cardiac surgery is the use of cardiopulmonary bypass. The cardiopulmonary bypass is excellent machine for saving lives, performing complicated heart surgery. But if the duration becomes longer, the complications related to cardiopulmonary bypass is directly proportional to the time. Now, in a surgery where we open the chest and do it, we everything is accessible, everything is easy. We do it pretty fast. In a small incision, it is going to take more time. We keep the heart ischemic, like we put a clamp on the heart and prevent it from beating. That's longer. Now, these complications can become profound after minimally invasive. That's my opinion. So it is not minimally invasive, it is minimal incision surgery. What I mean is minimally invasive. What is really minimally invasive is not opening and not giving anesthesia, not opening the chest, not using cardiac bypass. And that minimally invasive is TAVI.
Okay.
You know what TAVI is?
Uh,
TAVI is transcatheter under local anesthesia. A catheter is passed with a loaded valve, is inserted into the aortic valve and mitral valve without cardiopulmonary bypass, without general anesthesia. And that is minimally without that is minimally invasive. The man next day he gets up and asks for a beer or asks for a cup of coffee and walks up to the toilet. Okay, that is minimally invasive, in my opinion.
So, future surgery is always robotic. So, what about cardiac surgery, robotic surgery? Will it make surgeon comfortable? Because you operate for prolonged period, I think. If it is a triple vessel disease, many a times you go for, say, BG, and at that time, it is always some 7 hours surgery or so will it make surgeon comfortable or will it improve the success rate? What is your opinion?
See, for us to improve the success rate, we don't have randomized trials still, or controlled randomized trial. Now, with the case open, seeing it so well, we take such long time. Now, imagine in a small incision using a robot, it should take more time.
Okay.
So time is a problem, but it will grow. It will definitely become bigger. Like for example, when the robot came, it was used for prostate. Now, for prostate, I think the robot is extremely useful because it has to go under the pubic symphysis and identify the prostate, remove the prostate. If there is any bleeder, catch it. But they are now extrapolated the uh, use of the robot to other areas of other operational areas. Now we are the last people to use robot in surgical field. Everybody has stuck to robots. But we and the neurosurgeons are still thinking twice about using the robot. I'm not sure. I won't be able to give you a decent care. There is a surgeon in our hospital who does a lot of robotic work. Well, he's good. He's very good. But we are also good. But patients get carried away by the word robot. Mind you, the robot doesn't do the surgery. The man only does the surgery.
Yeah.
He just uses the robot for certain areas.
So, cardiac surgeries are always a prolonged surgery, and uh, you've been doing for almost 30 years. Probably you start at 7 o'clock in the morning,
Six,
6 o'clock,
six.
and complete it by 8 o'clock or 9 o'clock, depending upon the caseload. And how do you manage this prolonged surgery for almost 30 years?
No, we are, see the whole cardiac surgery is a teamwork.
Okay.
We don't do the we only do the most important part of the work, like the anastomosis, the replacement of the valve. But there are young surgeons who are aiming to become cardiac surgeons. Come and join us. So there are always two well trained assistants who help us out. They take care of the initial exercise, like opening, getting things sorted out. Then they ask us to come in, do the main work, and then we step back. Then they take over. If there is a problem, they call us. Then we come into the picture. So the work of the surgeon is not continuously 8 or 12 hours. But there may be busy surgeons, like we have in our hospital by a doctor by name Dr. L.F. Sridhar, and there's another very famous surgeon called Dr. Girnath, who used to do 3, 4 surgeries a day. Now they will have these assistants do help them to reduce the burden of work. They do very well.
Okay.
And certain surgeries, like for example, in aortic surgery, it takes longer time, where the junior doctors may not be in the position to do this because it's not a frequent surgery, it's an infrequent surgery. Or for example, the aortic dissection comes in the night at 11 o'clock. You can't expect your junior assistant to do all this. So we have to come in and get up and do it. It takes long time. It does take. Bleeding is a major problem in heart surgery.
So, can you please share us some challenging cases you have treated?
Okay, challenging cases. I remember I was sitting in my outpatient department at around 7:30 in the morning. A young man came from Bengal and brought his wife. In front of her chest, there are multiple openings. He said, "Doctor, my wife had a surgery in 2019 for a VSD closure and a ruptured sinus of valsalva into the RB. That's in 2019 January. Following which she did very well. In 2019 November, the place again developed infection of the chest wall, wound infection. As a result, she was bleeding. The surgeons in the Calcutta took her back, repaired it wonderfully, and she became all right. But unfortunately, the chest wound, the sternum did not heal. Now he comes to us in January to our hospital and says, "My wife is having this problem, but you should not operate on her because you see, I can't afford to treat this infection again, and there's nobody to treat the infection." So on a Friday night, I was about to leave home. I get a call from the ward saying that you have to come here immediately to see this lady. She was sitting up, and two nurses from the left side, two nurses from the right side was pressing the chest. Hello? Pressing the
Yeah.
chest. Can you hear me?
Yes.
Pressing the chest on either side to prevent bleeding from the center of the sternum.
Oh.
Then she asked me, "Doctor, if it happens, what can you do?" You said you can't do anything. If it happens to your mother, will you keep quiet? If it happens to your wife, will you keep quiet? I couldn't answer that question. So I went back and asked some of my cardiology colleagues to help me out. They said, on this night, we won't be able to get anything to do. We have to do something. Then I called a friend of ours who is working in our hospital, see if he can stent it. Well, he came to the hospital. He got a stent. He got in a stent from the vendor by a method called the green corridor, where the police keep the road open for just the passage of these materials for quick access to the hospital. So with the help of the green corridor, they got the stent here. This man put the stent within a matter of 15 minutes in the ascending aorta. There was a hole in the ascending aorta which is leaking. He just put it, and then he showed us the leaking, the bleeding has stopped. So I think that was a great thing that can happen. The modern science could help us, and the hospital helped this lady to go back her home safely. Unfortunately, she went to another hospital for treatment of the infection. But they tried to do something, but she died later on after 8 months.
So, do you think that after COVID, cardiac disease is significantly increased?
No, ma'am. No, no.
So, what is your final message to patients to prevent cardiac disease and after diagnosing cardiac disease, how do they maintain their lifestyle?
No, first thing, don't just because you're walking, eating, talking, and sleeping well, that doesn't mean you're all right. See, you need to check it. The American College of Cardiology says, look, if you're more than 40, you got to check yourself. If a lady is more than 45, you got to check yourself. Mandatory echo, TMT, lipid profile, and other necessary tests like urea and creatinine, liver function tests. Everything has to be checked. If your TMT is positive, you need to undergo an angiogram or a 640 CT. They know the amount of calcium score. Now, these help to identify the disease early. Once you know that there is a disease burden, if you go to a good cardiologist, he'll be help you to guide you better as to now we have drugs to reduce the disease, reduce the load. I'll tell you, I'll tell you the story of a cardiologist who in the early 1960s who had a heart attack. When they offered surgery, he refused because I told you it is the third commonest cause of death, heart surgery. So he, he created a diet for himself, which he stuck to it so religiously that at the end of 20 years, when he died, he requested to have a postmortem and angiogram uh, done for his coronary arteries. So when he died, they took his heart and gave an injection to see if the coronary artery disease, which was there 20 years back, whether it's progressed or it's reduced. They found, through their surprise, the load of the coronary arteries has decreased considerably. This was probably because of the strict diet which he undertook. But unfortunately, that diet only that doctor can take, nobody else can take. It was so strict. Okay.
So diet plays an important role
I
in
think so.
preventing.
Diet, exercise. You know something? In London, they compared in London, in the buses, the conductors are always moving and the drivers are always sitting down. They wanted to find out who has more coronary artery disease. So when they examined the drivers and the conductors, they found the incidence of coronary artery disease was less in conductors than in drivers. So they came to the conclusion that when the people are always constantly moving, there's one way probably to get it off, or reduce the burden of coronary artery disease. Now, this was extrapolated in America. How much should you walk to prevent or reduce the disease? They found when they tested people who didn't walk 10 minutes walking, 20 minutes walking, 1 hour of walking, they found that people who walked for 1 hour in a day, the incidence of coronary artery disease or the burden of the disease was less when compared with others, or definitely better than people who didn't walk at all.
So,
There's a simple example that some amount of exercise is always useful for the heart.
so we need to complete these many steps. The theory came after this 10,000.
Yeah. A lot of work, man.
You have also said you will complete your 10,000 steps sometimes in between your surgery going up
Yeah, how
and
do you know that? Who told you that?
you only told me.
Ben?
Long
No?
back, long back.
Long back. Yeah, I do that somehow. Even if it's 12 o'clock in the night, I must finish my 10,000 steps.
Okay.
It's important. I think it's important. It needs a lot of courage. Initially, I was very hesitant, but there is a saying in my country, in my state, from Tamil Nadu, anything we do for 20 days continuously, it definitely becomes a habit. So I did it, and now I cannot do it. I cannot go to sleep without doing the 10,000 steps. That's where my podometer, in the phone helps me to do that.
So many a times they stick to Apple Watch without completing their rings. They will not go to sleep. That becomes a habit for many of our patients
Yes,
also.
yes, 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 yes.
So it was a wonderful message to cardiac patients, and thank you so much for spending your time with us
Yeah,
uh,
it's pleasure.
and giving some ideas about prevention of cardiac disease. Thank you so much,
Yeah.
sir.
Thank you so much. Thank you so much,
I
man.
thank our Fogsi President, Sunita Tandulwadkar ma'am, for giving this opportunity. Thank you.
Excellent. Thank you for allowing me to talk to you people. Okay. Thank you so much. Great meeting you, ma'am.
Thank
Where do you work? Here in Chennai or in northern part of
Madurai,
the country?
Madurai.
Oh, in Madurai. My God. Okay. Where in Madurai?
Madurai proper, sir.
In which hospital?
Guru Hospital.
Guru Hospital. Okay, good. I used to come to Madurai to work with Dr. Sridhar,
Yes, yes.
who is an excellent surgeon. Okay. Right, Dr. Kalpana. Very nice meeting you. Enjoyed talking to you. Bye bye. Good
Thank
night. Thank you.